Hi, Walter.
Hi.
Thanks for being here. I first found out about you. I was watching 60 Minutes, a segment that you were on about antidepressants. You were commenting on the research showing that antidepressants have a placebo effect for many, if not most, depressed patients. So what brought you to this conclusion?
For years, I've been doing research on the so-called biology of depression, looking at uh, various kinds of brain mechanisms in depressed patients, and also looking at the antidepressant medications and how they work. And in the context of that, I had been involved in a number of clinical trials of new antidepressants. And these clinical trials were placebo controlled, and that is that about half the patients in a clinical trial who were depressed would get just a placebo, a sugar pill, and the other half would get the antidepressant medication. And one of the things that invariably happened was that a high percentage of the people, generally, 25 to 45%, who were treated just with the placebo improved. And that wasn't a much smaller number than the number that improved with the antidepressant, which was usually like 50 to 60%. And so I became intrigued with why that might be happening and started to do a number of analyses of large databases of people who have been treated with antidepressants and placebo to try to see if my colleagues and I could tease out some predictors of the placebo response. That is, could we figure out who in particular was getting better with placebo, and were there any particular symptoms that they had that predicted that? So that's how I got interested actually in the placebo effect in general. It was through my work with antidepressants and what struck me as an extraordinarily high rate of depressed people getting better with placebo alone.
Do antidepressants work beyond the placebo effect for some patients?
Yes, there's no question in my mind that the antidepressants do have something of an advantage over placebo for depressed patients, but it's not a big advantage. But they're not the same as placebo. I've never said that. I've said that there's a very high likelihood that people who are depressed can get better with placebo alone. But they're for particularly for seriously ill depressed patients, my take of the data is that the drugs are somewhat better than placebo, not by a lot, but by some.
And so maybe there's something special about depression, I would think, in terms of the placebo effect, because depression seems to be about demoralization. And so if you can give somebody some kind of hope, they're probably going to get better, right?
That's absolutely right. Demoralization is a big part of what people experience when they're depressed. And placebo treatment, just like psychotherapy, has as one of its important ingredients the reversal of demoralization. When you give people a placebo treatment or psychotherapy, they do experience some hopefulness, a sense that things could get better, and a reduction in demoralization. So that's a big part of it.
You've been a psychiatrist for a long time and a professor for a long time. The kind of conventional view, I believe it still is the chemical imbalance theory.
Well,
Go ahead.
yeah, that is sort of the conventional, what I would call the folk psychology view. That there's some kind of a chemical imbalance. And people learn about that in college, they learn about it in medical school, but it's a vast oversimplification. Yes, there is probably something going on at a biochemical cellular level in the brains of people who are depressed, but it isn't something like low serotonin, which is a very popular variant of the chemical imbalance theory. It isn't, the experts in psychopharmacology don't talk about chemical imbalances. We really don't know what is going on in the brains of depressed patients, and we certainly don't know how these drugs work. But we have some guesses about it, but we don't really know. So the chemical imbalance theory is sort of a shorthand for saying, well, there's something going on in the brain and somebody is depressed. Let's give them a biochemical substance, an antidepressant medication, and that'll help them. So it's sort of to provide a rationale for using these drugs, but it's a vast oversimplification. And whatever that imbalance is, we don't know much about it.
But when you say it's a vast oversimplification, do you mean that it's just the public that has this misunderstanding, or are there also psychiatrists in the field who would also have this oversimplification?
Unfortunately, both the public and some medical professionals have that misconception.
So one popular idea is that if you can raise the serotonin levels, then a person will feel better. I've read that experimentally lowering the level of available serotonin in healthy volunteers who have never been depressed does nothing to affect their mood in the slightest.
That's my understanding.
Okay. And I believe there's an Italian antidepressant that instead of raising serotonin levels, lowers serotonin levels.
Well, that's nothing I've heard of, but there are drugs that are effective antidepressants that don't do anything to serotonin, like bupropion, for example.
Mm-hmm.
And they're effective antidepressants, but they don't touch serotonin, which is a real blow against the so-called serotonin theory.
And so you don't necessarily completely dismiss the chemical imbalance theory. You just think that just focusing on something so simple as serotonin levels is what the problem is. You think
Correct.
that it, okay. Now what about alternative views? So for example, like the cognitive behavioral therapy view that what's causing your depression is your thinking.
I have to say, full disclosure, I am not a big advocate or fan of the cognitive theory of depression. I think, again, it's an oversimplification. Yes, there probably are some people who, if you tell them to think different thoughts, are going to feel a little bit better. But for people who are mildly depressed, that is, don't have to be in a hospital, but are kind of low and their appetite isn't quite good and their energy is a little low, those people are going to improve no matter what kind of treatment they have. They'll improve with an exercise regimen. They'll improve with a variety of alternative therapies, from massage to magnets and the herbal tea, and they'll improve with antidepressants and placebo. So, I think what's most important when we think about depression, how to treat it, is that all of these treatments work about the same, particularly for people who are mildly to moderately depressed. And the theories behind them are sometimes rather compelling and elegant, but they're not necessarily true.
What do you think is the best treatment for anxiety? Is there any difference? You said that a lot of different therapies are kind of work the same with different problems. Is there anything special about anxiety or maybe phobias or something that maybe responds to a specific treatment that doesn't respond as well as something else?
It depends on the kind of anxiety. Things like phobias, like people who are afraid of flying or afraid of snakes and stuff like that, can respond very well to psychological treatments, so-called behavioral treatments, where people are exposed to what they're afraid of and supported, and called systematic desensitization. There are whole lots of psychological approaches to the kind of anxiety that you experience with a phobia, like fear of flying is a very common one, or fear of heights. But what's called generalized anxiety, just people who are nervous a lot of the time, my sense is that the best treatment for that is one of the medications we have, particularly the serotonin reuptake inhibitors, like sertraline, Prozac, and so forth, fluoxetine. They work quite well.
If the premise for a lot of psychiatric drugs is that they are correcting some kind of chemical imbalance, how is it that these conditions can be diagnosed and drugs be prescribed without some kind of blood test or other test that shows there is this supposed imbalance in this patient?
Well, the imbalance it's a hypothetical imbalance. It's a presumed imbalance. We just don't have we don't have tests that demonstrate those kind of imbalances because there's no, we can't really measure the chemical activity in relevant places in the brain. So we don't have those kind of tests. They're not available.
And so that doesn't pose a problem, let's say, for the efficacy of the treatment, but it poses a problem when we try to speak intelligently about the theories behind them.
Correct. It's just like, we don't necessarily know exactly how aspirin can alleviate a headache, but it still works to do that. And that's true for a lot of other medical conditions, although for a lot of medical conditions, we do know how the drugs work, but sometimes we don't. But nonetheless, we prescribe them because they have clear effectiveness.
Tell us a little bit about how these psychiatric drugs were often found. A lot of them, I think, if I remember correctly, were found maybe around the 1960s and haven't improved much other than the side effects getting better. And isn't it because a lot of them were found by accident?
Absolutely. Lithium was probably the first drug with a specific use in psychiatry to be discovered. And it was discovered largely by accident. An Australian psychiatrist named John Cade was injecting guinea pigs with all kinds of salts and other substances and happened to try a lithium carbonate on them, and it calmed them down, which gave him the idea that it might work for mania. So that was somewhat accidental. And, the antidepressants were the two major classes of antidepressants, one known as monoamine oxidase inhibitors and the other as tricyclic antidepressants, were both discovered when people were looking for something else. The MAO inhibitors were discovered because they were used in the treatment of tuberculosis, and some tubercular patients being treated with them became euphoric, which gave some bright psychiatrists the idea that it may be an antidepressant. And the tricyclics were discovered by a Swiss psychiatrist named Roland Kuhn, when he was looking for another drug that might alleviate the symptoms of schizophrenia, and found that the drug that he was studying actually got people out of depression. So he wasn't expecting that. So those are two examples, and almost invariably, not always, but more often than not, these drugs have sort of been stumbled upon. And then the person who stumbled on them was a good observer and was able to understand that there might be something of importance here.
And then we don't necessarily make great improvements upon them because we don't know how they work since we found them out accidentally.
Right. That's pretty much the case. If we knew more precisely how these drugs work, the pharmaceutical industry and biology researchers could then design drugs to do what we want them to do. But we don't know enough about how they work. It's a real problem. And as you said, there really hasn't been an improvement in these drugs in 60 years. They have somewhat better side effect profiles, but that's about it.
Yeah, Pronazid, I don't know if I'm saying that right. That was tried on, I think it was used for tuberculosis. And, researchers found that these patients were getting less depressed.
Right.
And so it ends up being the first antidepressant. And, it was never tested against a placebo. But so we don't know how it fared there. But it's interesting when we think about, I had made this point to you before, I think, when we think about some of the people who might say that antidepressants are purely a placebo. Well, if that were the case, then how come these tuberculosis patients who had no idea that this was going to become a future antidepressant, that there was no expectation that by taking this pill that they should become less depressed? Why would they have that effect?
That's an excellent point. That ipronizid, which was one of the first antidepressants, inhibitor, nobody had the expectation that it would alleviate depressive illness. And as a result, the fact that it did is much less likely to have been a placebo effect. You're absolutely right.
You called lithium the greatest psychiatric discovery of the 20th century. Why?
I don't remember that I used that much hyperbole, but well, it was the first drug to have an effect to have a curative effect in a psychiatric illness. I mean, before lithium's anti-manic property was discovered in 1949. Before that time, patients with severe psychiatric illness were treated with drugs, with Benzedrine. They were treated with opioids. They were treated with high doses of sedatives, but none of those drugs actually worked very well. They might put these people to sleep or relieve their symptoms very briefly. Lithium was the first substance that actually brought about relief of a major psychiatric illness, which was mania. John Kay gave it to 10 patients who were hospitalized, and they were able to go home. They were able to resume work when they hadn't been able to do that for years. And following lithium, other drugs were discovered within the next 10 years. Chlorpromazine for schizophrenia, the antidepressant drugs were then discovered. But the real magic of lithium was not so much that it calmed people down who were manic, but it prevented episodes of mania and depression, which really turned around the lives of people with manic depressive illness, or what we call bipolar disorder.
Bipolar is rather serious. I think, I don't know. I think a lot of people, we kind of joke about it sometimes, saying like, oh, I'm bipolar, without being diagnosed, kind of, exaggerating. And I didn't realize how serious it was until I met somebody who was on lithium, and he explained that what a manic episode was. I didn't really understand. He was driving a cab, and he got out of the cab and he started yelling and laughing hysterically and acting like a complete loon. And they had to call, the cops. And I asked him, like, what was that like? And he said, oh, I was having a great time. What is bipolar? What are some of the symptoms? And I want to know, like my friend there, he didn't want help during the manic phase. Maybe you can tell us about that too.
Yeah, well, that's pretty characteristic of people who are bipolar. They don't think they need help. I mean, bipolar disorder, the older term is manic depressive illness, is characterized by episodes of mania, which involved a high level of activity, irrational behavior, nonstop talking. Sometimes people get very, very angry and violent, out of control, and it can go on for months. And people can really wear themselves out and act in very dangerous ways. And those episodes periodically shift into very, very severe depressive illness, where people want to hurt themselves, they can't get out of bed, they don't eat or sleep. It's like a dark cloud descends on them. And so they vacillate between these periods of very, very severe depression and this hyperactive state, which we call mania. And when people are manic, particularly when they're not as severely manic as some get, which is called hypomanic, they don't think there's anything wrong with them. They have a tremendous amount of energy, a lot of sexual energy, a lot of creative energy in terms of starting new endeavors. And so people usually don't think there's anything wrong with them. It's a very difficult condition to get people into treatment for.
And so if they do go into treatment, is it more likely going to be during the downfall? It's going to be the depressive phase?
People get into treatment both ways, but if it's in the manic phase, it's more because either some societal institution or the patient's family brings them to treatment because they're behaving so irrationally. They don't. A manic person is unlikely, not invariably unlikely, but not likely to show up for treatment on their own to seek it out. They don't think there's anything wrong. People who are depressed are more likely to do that.
You mentioned hypomania. That to me is so interesting. So you have people who have kind of the fast speech, high energy, less need for sleep, big ideas, more confidence. You see this a lot. It's been speculated, I guess, with CEOs. It sounds pretty terrific. Is it?
I think the short answer is no, because keep in mind, hypomania means, I'm not sure what the derivation of hypo is. It means under, it means less. So these are people who have some manic symptoms, but they're not as extreme. Some people think, that who have periods of hypomania, that it kind of does throw their creativity into overdrive and they can accomplish more. But there's very little evidence that when people who have bipolar illness are treated and they stop having these episodes, that their creativity actually decreases. If anything, for example, their artistic creativity seems to increase with treatment.
Can you see advantages? I mean, in fact, there's a book called The Hypomanic Advantage or Edge. Can you see advantages with hypomania?
I think it really depends on the person with the hypomania. If along with hypomania, a very typical thing of somebody who's hypomanic is that they make all kinds of plans, professional plans to start a new business, to write 10 books, and so on. So I think it depends how rational the person is during a hypomanic episode. If they're doing all kinds of things that don't make a lot of sense, no, it's not an advantage to it.
We hear a lot about, depression gets kind of romanticized with, artists. Do artists have higher rates of bipolar? And if so, why?
They do have higher rates. Particularly, there's a particularly high rate among poets of manic depressive illness, but also among visual artists and other creative people. Why do they have it? I mean, one theory is that some of these is that somehow the gene for bipolar illness, and it is a genetically based condition. It runs in families, and there's a clear genetic component. That gene also confers some creativity on people. I mean, that's one theory. And supporting that is the fact that the family members of people who are bipolar, but who are not bipolar themselves, often have higher scores on measures of creativity than other people, which suggests that the gene there is doing something around creativity.
Pharmaceutical companies must hate lithium. It's a salt, right? So it's a natural thing that they can't put a patent on and charge a lot of money for, right?
Uh, Hate sounds a little strong, but you may well be right. I mean, it took a long time for the FDA to approve lithium in this country. In fact, I think we're the 50th country in the world to approve it. And part of the reason is no pharmaceutical company was applying for approval because, as you said, it's a natural substance. They can't patent it. They're not going to make any money on it. But there are pharmaceutical companies that ended up making it. But what they've done is market other drugs that are also so-called mood stabilizers quite heavily, like Depakote. But the pharmaceutical industry, I mean, you're right, is not a big fan of lithium because they don't make anything on it.
What happens if somebody doesn't get on the medication? A lot of people die from this, huh?
Very high rate of suicide and untreated manic depressive illness. Something
20%,
like
I've heard.
20% of untreated people do it. And when they get on lithium, it reduces the suicide rate dramatically. And lithium is really the only drug that has that profound an influence on suicidal behavior.
Why can't someone diagnose themselves? If I've got the diagnostic manual that psychologists and psychiatrists use to diagnose people, I've got it. It tells me, if you've been depressed for 2 straight weeks, if you've been sad, and I look at the criteria. Why can't a person diagnose themselves?
Do you think they can diagnose themselves?
No, but I don't know why.
Okay.
Is it just a matter of perspective?
No,
That
I think it's a matter of context. It's the same thing with diagnosing yourself with a medical illness. Lots of people get on the internet when they have symptoms, and then they give themselves all kinds of diseases, including psychiatric ones. But the problem is when you read a list of symptoms that is taken from the DSM, the Diagnostic Statistical Manual, it doesn't put it in any context of how rare or common or anything it is. Let me just give you one simple example. One of the symptoms of schizophrenia, which is a very severe psychiatric illness, is hearing voices. But sometimes people can hear a voice and it really doesn't necessarily mean that they have anything wrong with them. But because you have to take into consideration what else is going on in their lives and why they might be hearing the voice and what kind of a voice it is and what the voice is saying and all that sort of stuff. So, for example, if you wake up in the middle of the night and you think you hear your dead mother calling your name, that's something you've heard a voice, but that's something very different than in the middle of the afternoon hearing a voice telling you to slit somebody's throat. So, so I think that's one of the problems, that things are taken out of context. And it's also true that, it's very, very hard for a person who is not a medical expert to understand the significance of certain kinds of laboratory test abnormalities. If somebody just looks at the results of the laboratory test and see, oh, this thing is out of the normal range, they can get worried. But your doctor may know that, yeah, that is not particularly significant. So I think that's a big part of this, that just hearing or reading about a symptom doesn't give you enough information to make a diagnosis.
I read in a psychology book that was written probably 30 years ago, it said that there are only two psychological disorders that are completely curable: blood phobia and panic disorder. Is that still true?
No. I mean, it depends what you mean by curable.
The person gets treatment, they go away, and it's gone.
No, that depression is curable in that way. Attention deficit hyperactivity disorder is.
But they're taking a drug, though, aren't they? I wouldn't consider that curable if you're taking a drug every day.
Oh, okay. No, depression is curable after a period of treatment. You don't have to continue taking the drugs and it's gone away.
Okay.
I don't know why somebody would have come up with blood phobias being curable. There are other phobias that are also curable.
Okay.
Spider phobias, snake phobias, social phobia. Yeah.
What are the common factors we often hear about in therapy, and are they considered a placebo?
That's a great question. The common factors are the factors that are ingredients of all of the psychotherapies, and that some people think are the active ingredients. And so for whatever therapy you're getting, every therapy involves somebody going to an expert. So there's an expert. You get a label for your condition. The expert provides hope by letting you know that there's a treatment available that they're going to provide and that it can work. You get some kind of treatment that has some sort of rationale or theory behind it that creates the expectation that you're going to get better, and all of these things help to reverse demoralization, which is part and parcel of most of these illnesses. So the common factors are the factors that all therapies have, and that are probably the active ingredients of all of them. A chance to talk about your problems, have a sympathetic person listen, going to an expert, having an authority telling you what's wrong with you, all these things are helpful.
So wait, they're the active ingredients, but they're also probably a placebo?
Well, those active ingredients are also present in any placebo treatment.
Right. And is empathy part of that? I always hear about the importance of empathy of a therapy. Don't be like Dr. Phil. Is that's included in there too?
Yes.
So you take one group, you give them the common factors. Okay, no treatment. Give another group, I don't know, maybe the common factors, and you give them the treatment. So in CBT, you teach them how to challenge their negative thoughts. What happens? Do we find out whether therapy is a placebo that way?
In general, I think it's fair to say that the common factors alone, in most instances, are going to provide the same outcome as the common factors plus a specific treatment.
So that therapy
Psychiatric problems.
So that therapy largely probably is a placebo, without getting into specific cases.
There's a big component of that, yes.
Placebos are fascinating. Tell us about how they work. And I've heard that you can take if you take a blue one, it's going to give you a different effect for certain things versus a red one, or if you take 4 compared to taking 2. And it's fascinating because they're all just sugar pills, right?
Right. Well, a while ago, I put forth the concept that a better term than the placebo response is the response to the treatment situation. because whenever people get a placebo, they're getting all of the common factors of treatment. And I think it's those common factors that really account for why placebos work. Going to an authority, getting empathy, having losing some of your demoralization, having a medical examination and an evaluation. All of these things give people hope and reduce anxiety, which is a big part of how placebos work. And there's a lot of evidence that things like how long a doctor spends talking to people has an impact on their outcome. How sympathetic they are has an impact on their outcome. How careful a diagnostic evaluation people get has an impact on their outcome. And all of those things are part of placebo treatment and how placebos work.
And so if you were to, bother learning a therapy, I mean, part of me thinks like, why do you try so hard to learn cognitive behavior therapy or Freudian therapy if what you're doing is largely a placebo? But then I guess if you weren't that convincing, then that would be a problem. So in a way, you're kind of learning some of these things to make the placebo work better.
Right.
That's interesting. Can somebody then use a placebo on themselves? I mean, like I see people always say, vitamins are useless, but to me, it's like if I can spend $10 on a bottle of vitamin D and tell myself it's gonna, do great things, to me, it's kind of a no-brainer.
If you think it's going to work, it may well. Like the vitamins, for example. If you think they're going to work, you have a chronic cough. You think that vitamin D is going to help it, and you take some vitamin D, you may well get some relief of your cough on the basis of the placebo effect, the creation of positive expectations.
So it sounds like
placebo is all about. It's about having the expectation that you're going to do better. And that expectation is often a self-fulfilling prophecy. People experience from taking a substance what they think they're going to experience, whether they think they're drinking an alcohol-containing beverage, but they're not, or if they're drinking caffeinated coffee, but it's really decaffeinated, they're going to have all of the reactions that you get from that substance that they think they're getting.
You're really making a case for optimism here. I read a book recently about conscious luck, making yourself luckier. And at first glance, it sounds kind of a silly idea since luck kind of presupposes that it's outside of your control. But when you think about it, and in the way that you're saying it, seems like, a lot of ways we do make our own luck. You see the girl at the other end of the bar and you tell yourself, oh, she's probably with somebody or she's probably not interested. Well, yeah, you're making your own luck, right? I mean, it's kind of what you're talking about, right?
Yep.
What about affirmations?
I'm not sure.
Self-affirmations, people, mantras, people say to them, I'm getting, healthier and healthier every day, things like that.
If it works, I'm all in favor of it. And I can see how that can create expectations. Absolutely.
And so when people often say, it's just a placebo, you hear this all the time. But it's just a placebo. It sounds like that's an incredible misunderstanding of placebos.
It is. Placebos are extremely, the placebo response and placebo effect are extremely powerful, and they're a central part of all healing. Every treatment that somebody gets has a component of the placebo response to it. That is the expectation that you're going to get better, and that's very helpful for people.
Lastly, tell us about, this is so interesting, open label placebos.
Ah, yes. For a long time, there's been this idea around that in order for a placebo to work, the patient has to be deceived. They have to be told that what pill you're getting them is not a placebo, but it's a vitamin or an antibiotic or something like that. Otherwise, it won't work. And in the 1980s, the American Medical Association came out as a policy. This may sound strange, it wasn't there before. You can't lie to patients. So, although placebos were widely used in the 19th and first half of the 20th century in this country, and in fact, physicians were taught how to use them and were told that they should give patients placebos and tell them that they're various kinds of drugs, particularly when nothing was available. That became considered unethical. So there was a dilemma. Can you give people a placebo and tell them that it's a placebo? And a number of people, including myself, suggested that, yeah, you probably can. That you can tell people, I'm giving you this pill. We don't know how it works. It doesn't contain any medicine, but some people improve with it. And there have now been dozens of studies showing that so-called open label placebo, that is, you give people a substance and tell them that it's a placebo, actually does have some beneficial effects. And there's more and more work being done on this. There's a whole line of research trying to develop ways to reduce the use of opioids by substituting placebos for opioids in some instances.
Yeah, that's so interesting. So, you'll often hear people rail against homeopathy or acupuncture, kind of, say that, oh, it's not proven and it doesn't work. It sounds like the kind of counterintuitive thing is by looking it up and finding out that it doesn't work, you're actually doing yourself in a way a disservice. It would be better to just go into something like acupuncture and say, hey, yeah, people say it works.
Absolutely.
I should do it. Interesting. And so most doctors, most primary care physicians have admitted to prescribing a placebo.
They admit that not infrequently, they will give patients like what are called impure placebos, a very low dose of a drug below the therapeutic range in order to mobilize a placebo effect, like a vitamin or something like that. Doctors now really don't, as far as I can tell, give people open label placebo, that is pure placebos, and tell them what it is. But they will give them drugs with the idea in mind of mobilizing a placebo effect, if you can see the difference.
Anything you want to plug, Walter?
About 2 years ago, I came out with a book about lithium. The results of some of which I mentioned here, called Lithium, a Doctor, a Drug, and a Breakthrough. It's an interesting story. I tell the story of the discovery of lithium.
It is a very interesting story. And where can people find you, Walter?
I don't have a Facebook page or anything like that. Where can they find me? They can get my book on Amazon.
Okay.
Like that.
I read some of your papers on your website too. If you Google search Dr. Walter Brown, MD, or Brown University. Okay. Thanks, Walter. This has been great. I really appreciate it. Thank you.
My pleasure. Bye.
Thanks. Bye.